Welcome back to the Happy Moms Project. I am so excited you've decided to spend more time with us today. Today is going to be a very special episode and very dear to my heart. And we have a very special guest, which I cannot wait to introduce. But I want to talk to you girls, you ladies, you amazing women about something that is very controversial, but it's something that completely changed my life. And that is the moment that I realized that I had breast implant illness, and the moment I realized I had to remove my breast implants after 13 years of having them. Now, 13 years, I took them out at 31. You can imagine my entire adult persona was literally built around me having these implants. And from one day to the next, they started making me very, very sick. I went to many doctors. A lot of them told me that what I had was in my head, that it wasn't a thing, that it was not my implants, until I found Dr. Josh Lampert, who happens to be here with us today. Thank you, Dr. Lampert, for being here.
Thank you. Yeah, thanks for having me.
Yeah, so amazing to have you. I mean, I've told you this many times. Literally, like, visiting you was life-saving for me. If I would not have removed my implants, God knows where I would be right now, because I was already, I mean, you remember, to the point that I was so sick when I walked into your office. Remember, I couldn't breathe. I was crying all the time. It was very hard, especially because, again, I had been to so many doctors who had told me that it was not a thing, right? And you came very well recommended. And I remember I had gone to see other surgeons who specialized in this. And I remember walking in, and it felt like a meat market. It felt like he was just trying to get me in and out. And then I walked into your office, and you were so kind. You took your time. You explained it. And I was just so happy to be there. So, yeah, I mean, I think you were probably one of the first ones to understand this was a thing, right? And you didn't gaslight women into what they were feeling.
Yeah, well, I think my approach always is to listen to the patient and see what they want. So,
Yeah.
Initially in training, I think breast implant illness, it's not really, it wasn't taught to my generation, So as a resident, as a medical student, I look back and, it was over 20 years that I was an intern in plastic surgery. And this wasn't something that wasn't described. It was described rarely in publications: Asia syndrome, silicone sickness syndrome. So these things were described. But I think it really wasn't until social media gave women a voice to, really complain about this and say, I think my implants are creating problems, or I felt better when, and it became like a support group for people going through this. So, and to be honest, in the beginning, when I started doing more of these, I'd always done breast reconstruction. And when you do that, you do a lot of breast implant revisions in Miami, because people get breast implants at a very young age down here.
Right.
And you start to see patients who've had many, many operations on their breasts before they're 40, and ultimately some of them get frustrated, they get frustrated and remove their implants.
Yeah.
So when you would see those patients say they feel better, and certain sickness, illness, fatigue, hair loss, even return of early menopause, you see these symptoms, so you start to kind of believe it. But my attitude was always, if a patient wants her breast implants removed, I'll remove them.
Yeah.
Obviously, there are aesthetic consequences to this, and the patient needs to know about that. So I think part of it is outlining, okay, if you were an A cup before and you had an 800 cc implant placed, obviously there's going to be a big change to your breast when you get it removed, and how bad do you really want to do it?
Yeah.
So, initially patients would come in, they'd say, I want my breast implants removed for XYZ. And I would say, you don't really need a reason, but let's talk about why and what's motivating you. And some people it's pain, some people it's breast implant illness, some people they've been in for 30 years and their heart is a rock, and they're 70 years old. They don't want to do another surgery in 10 years or something. It's just not the priority anymore. So, listening to patients and then moving forward with explant surgeries on patients for whatever reason. Some patients just say, I want them out.
Yeah.
But then I would see so many patients that say they felt better, it was hard to deny it. And what's really interesting, I go to the aesthetics meeting and the American Society of Plastic Surgery meeting, kind of alternating every other year. We have to do continuing medical education. We have to go to conferences. And before 2021, there would maybe be one conference, 30 minutes on Sunday, and everyone goes out Saturday night with the reps and doesn't make it to Sunday. So I went to one because I was doing a lot of explants, and I went to one. It was the Sunday morning conference, and there was no one there. and it really, there was some interesting stuff, but it wasn't like groundbreaking. And then I think it was like it was after like kind of that COVID lift, like 2022, something like that. We went to San Diego. And then more recently here at Miami, the aesthetics meeting, and it was like every room, like there were multiple BII conference, like
Yeah.
multiple things I wanted to see, and I couldn't see them all at the same time because there was just so much information that
That
people
makes
were
me so
sharing.
happy though.
And I think what it is too, it's like when, unfortunately, a lot of this in I mean, this is the problem where in healthcare and just on a bigger global, we've lost trust in patients a
Yeah.
lot of times because, and part of it's like how we're trained, right? You go to medical school, you read the journal editors often write the textbook, and that's kind of just been the long established way of passing on medical education. And, for plastic surgery, a lot of the editors for the journals work for historically the implant companies and this type of thing. So it's like you're always wondering, like, okay, what gets through? Now they have to declare, who they work for, and
Yeah.
and that's an important
But no
part.
one reads that fine print.
Well, it makes you wonder. So, and I
Yeah.
think a lot of it too is, we didn't know. We really didn't know as a field. I think we're learning. We still don't know how to like test for it or
Yeah.
know who, and we still don't even know the incidence because
Yeah.
it may be overreported, it may be underreported. It's hard. So it's hard to say like this is the percentage of people that will get it. But since you had your implants removed, now the FDA requires a black box warning on the breast implant box, which by the way, you never see, like a
Never
pack of
once did I see it.
cigarettes.
Yeah.
But a pack of cigarettes, like you look at that and you open it right before, hopefully.
Yeah.
But you don't see the box. The nurse opens the box and sterilely and throws it in the garbage. But breast implant illness is on the FDA's website now,
Yeah.
right? It's a black box warning on the implant box, and it's part of, I think, general education now. I would imagine in residency programs, which it wasn't when I was there.
Yeah.
So it's changed a lot, and I think that anyone that denies it, which there are probably still a few old school plastic surgeons that are like, it doesn't exist.
Yeah.
But I think that you will see less and less of that in the future.
That makes me so happy because I think my surgery was March of 2021, right? And I started feeling really, really bad 2020. I mean, some of my symptoms were like anxiety attacks, panic attacks. I remember I was at the dentist one time and I had a cavity that was being filled, and he numbed me and I started feeling like I couldn't swallow and I thought I was going to die. And it was so bad. And my dentist is my friend and he's like, "Are you okay?" I'm like, "Dude, I can't do this." And I had to call my sister because I couldn't even drive home. So yeah, internally I was like not well. And I remember walking into your office. Remember, I was like, I couldn't breathe, and you were like, "You're okay, you're gonna be fine." But that was so bad. And then I remember getting like really bad acne where I never had acne before, and I would get a facial every week, and my facial lady's like, "I don't know what else to do to you. I've done lasers, I've done cleansings, I don't know what else to do," and it just like kept coming out and coming out, and I had so much inflammation. And I mean, my symptoms were bad, but I want to say they were mild compared to some of the ones I've heard. Like I've heard people that get chronic disease. I've heard people that can't have infertility, basically cannot have children. Like it's pretty crazy, right? So, I mean, what do you think about the symptoms? If someone's listening to this and this is the first time they hear about breast implant illness, like what should they be looking out for?
Yeah, I mean, it's definitely a diagnosis of exclusion. So it's
Yeah.
hard to say, like, I've got breast implant illness. And
Right.
I will have patients that will come to me and say, I have alopecia. I have no other problems, but my hair's falling out and I have breast implants. Should I get my breast implants removed? And
Yeah.
it's very hard to direct a patient. Once in a while, I will get a patient sent from a rheumatologist that has lupus or has rheumatoid arthritis, and the rheumatologist thinks it'll help to get the implant removed.
Yeah.
I think your primary care physician had
Yeah.
recommended you
My
remove your
doctor,
implants.
my doctor did. Yeah. He had checked my hormones and my estrogen was all over the
Yeah.
place. And the big one was my heavy metals. My mercury was like 3 times the
Yeah.
amount.
Yeah,
It's pretty bad.
I get that once in a while, but it's
Yeah.
not often. And it is helpful, I think, for the decision-making process if there is another
Yeah.
doctor who's like, you should do this. But often that's not the case. And we have tried to look at the metrics. Unfortunately, you have to go through an ethics review board to survey patients through the university that I'm a
Yeah.
clinical assistant professor at. So it's hard to get those metrics to really because it would be nice to say, 70% or 50% or whatever it
Yeah.
is had improvement of alopecia with implant removal. So it does become a diagnosis of exclusion. I do think it's helpful, when patients do have these kind of autoimmune disease type of symptoms,
Yeah.
that they see a rheumatologist for. I mean, it's great if they see a rheumatologist first. At least that way they can check that box
Yeah.
and go through and see. Because sometimes, okay, we also remove implants for chest pain.
Okay.
Patients will have breast implant associated pain. We looked at it was like 15 to 20% of our explants either see the cardiologist
Really?
or go to the emergency room with chest pain because they think they're having a heart attack.
Wow.
But more than once, we've had patients where they actually were having a heart attack or cardiac ischemia and required some type of intervention with the cardiologist.
Okay.
So you just want to make sure, like, okay, is this symptom breast implant illness, or is it something like we can diagnose that's
Right.
different, right? So, and I think it's also difficult. One of the other like curveballs, and this is interesting, I've seen quite a few patients who have ruptures where the silicone has spread to their lymph nodes already, and they feel like they have breast implant illness, and they will decide to remove their implants. And I used to send everyone to the surgical oncologist because they're the ones that really remove a lot. I remove lymph nodes once in a while if they're
Yeah.
superficial, but I'm not going after the deep lymph nodes that are
Right.
around all the important vessels that go to your arm and stuff like that. So I'll refer them to the surgical oncologist that does that, and he'll say, I'm not taking out those lymph nodes because that'll create lymphedema or a swollen arm or that type of thing. But what's interesting is a lot of the patients that come in, I can't think of one that didn't complain of BII with silicone spread, where we remove the implant and they say they feel better. But it's almost like counterintuitive because you think that silicone has spread already. It's
Yeah.
there, and I'm not removing it all, but maybe debulking it
Yeah.
is some benefit. I'm not sure.
Wow, that's so crazy. And I hate to generalize because I feel like, I mean, in my opinion, I don't think anyone should be getting breast implants. Just because, like, why risk it? I know there are people who don't have a problem with it, but I mean, I had 3 sets of implants by the time I met you. So I had 3 surgeries. I had saline for about 10 years, and and one of them was actually like, I want to say it was leaking. I know saline's way different than silicone, so like it's similar to the body's fluid, right? So
Yes, I mean saline salt water, but your
yeah,
body will absorb it.
right. So I don't think it was that bad.
Yeah.
My big issues, I mean, I had like brain fog and so on, and weight gain those 10 years. But it wasn't until I switched to silicone that it was like right away, right? So I mean, how often does something like that happen where like the implant will explode? And what are the signs that someone should not explode? I don't know if that's the right term, but
Rupture.
rupture. There we
Yeah.
go, medical term. But how often, like, how can someone check for that? Because I feel like I didn't feel anything when it was my saline. With my silicone, they never ruptured, but they were hurting me. They were encapsulated. But to my point, like, there's a lot of women who are like, oh, I've had them for 10 years. I've had them for 15 years. I don't know. Should I take them out? I don't want to do another surgery. And it's like, what if it's leaking? What if,
Yeah, I mean, so the number one reason that you have to remove or replace implants is actually capsular contracture. It's
Yeah.
actually the scar tissue that forms around the implant. It encapsulates the implant in scar, and then that squeezes the implant. It can make the shape weird. It can cause pain. It can pull it out of position.
Ugh.
So that's like, and I think you had a little bit of
I
that
had
going
that.
on.
Yeah,
pretty
actually, what's
on
crazy?
one side.
Like, it might be all mental, but literally my
Yeah, you
left
had
side my chest is in pain right now. And it's the same pain I used to feel. So I wonder if it's just my
Thinking about it.
PTSD.
Yeah, you had capsular contracture.
Yeah.
So the number one reason that people get removal or replacement is some type of capsular contracture,
Yeah.
and that can happen early or late.
Yeah.
We expect it with time. If implants are in for long enough, it's going to happen. But it's weird because some people will do 20 years with no capsular contracture,
Yeah.
and some people it happens in like 2 to 3 years. But the average is roughly 10. So that's the number one reason. Rupture though happens. I think like the older implants ruptured more. I think now it's like 6 to 12% at 10 years, depending on like which study. And there's all different studies. Some will say less or more. But with saline implants, it's an easier diagnosis because basically the salt water gets absorbed.
Yeah.
So a patient will notice deflation of the breast.
Yeah.
So once in a while I'll get patients, they'll call on a Friday. I need like the implant deflated. Like
Yeah.
now all of a sudden they're walking around lopsided. They need surgery right away. Something,
Right.
removal, replacement, whatever.
Right.
So you get this like emergency breast surgery. But with silicone, you don't know.
Yeah.
And you can have an occult rupture. In fact, a lot of patients think they have a rupture because they feel something weird, but it's
Yeah.
that capsular contracture they feel, not
Yeah.
not a rupture.
Yeah.
With silicone, you can have a rupture that stays inside the capsule.
Yeah.
That's called intracapsular rupture, or extracapsular if it cracks and then it starts to spread.
Yeah.
Now, when it spreads, your body will form another capsule but it kind of like keeps going, usually along the lymphatics to the lymph nodes when it ruptures.
So dangerous, right?
Well, medical grade silicone, it's not dangerous like the industrial grade silicone that people are,
Used
you
to
hear
do.
someone get
Yeah.
injected by
Like,
the airport in some hotel by a non-surgeon, something
or
like that.
South America.
Well, we see it still here.
Yeah.
And, that's more dangerous. Medical grade silicone, people used to inject it in people's faces before fillers. It's
Crazy.
pretty common with board certified dermatologists used to do it down here.
Really? Wow.
In fact, some very well-known ones did because they didn't have other real options. But
Yeah.
we think medical grade silicone's relatively safe, again,
Yeah.
according to studies, but it can cause problems. And I think that we're better understanding it now.
Yeah.
But back to the rupture, so it's not like at 10 years you have to get them removed or replaced, and then at midnight it turns into a pumpkin type of thing. It's like
Right.
you're supposed to, at least according to the FDA, you're supposed to get 5 to 6 years after silicone breast implants, because you can't really tell if they're ruptured by clinical exam.
Okay.
5 to 6 years after, you're supposed to do at least an ultrasound or an MRI. The problem is ultrasounds miss a lot of them.
Yeah.
MRIs pick up 97%, but MRI is an expensive test.
Yeah.
People are claustrophobic. Insurance often doesn't cover it. So, like 5 to 6 years, you're supposed to check it, and imaging is really the best way. We have had patients who have had both red ruptures and non-ruptures. You figure if it's 97% accurate, 3 in
Yeah.
100, you're having a false reading.
Right.
So, ideally everyone gets imaging, but the reality is they don't.
Yeah.
So I think that's kind of like if you're trying to monitor a rupture rate. But what I tell patients is, if you have implants, you should be checking in annually with your plastic surgeon.
Yeah.
And that's my opinion. People, sometimes don't feel that way, but I think, there is a point where implants should be at least, if not removed, replaced.
Yeah.
And, when they start to get hard, when they start to get painful,
Yeah.
because it's easier to do sometimes early than if the silicone ruptures and spreads. And, there's certain
Yeah.
things you can do to avoid that. And then, I have, more than a handful of patients that have had silicone spread to their lymph nodes, where one of those lymph nodes becomes inflamed and painful, where you're doing another surgery to remove that.
Yeah. Oh, I'm like having flashbacks of how sick I was. And I remember my second surgery, where it was like a tennis ball. My left one became, for some reason, my left one was always the issue with the saline, with the silicone, and with the capsular contraction. It was so painful. I couldn't even lift my arm. It was just so
Yeah.
painful. It was like a tennis ball, literally.
Yeah.
And it's a lot.
You were under the muscle. And
Yeah.
when you think about pec major, there's a reason it's called major. It's like
Okay.
the largest muscle on the front of your chest.
Yeah.
And it's what allows you to do push-ups, bench press, or push or hug.
Yeah.
Right. So when you put an implant underneath that muscle, the biomechanics change significantly, because
Yeah.
now this muscle's got to stretch over from it inserts on the sternum, it inserts on your humerus and down to the rib cage.
Yeah.
So when it's released, it slides up. And it slides up a little bit like a curtain shade,
Yeah.
but in order to kind of like move normally, now it's got to go over that breast implant.
Yeah.
And I've seen quite a few patients who have limited shoulder mobility. We had one recently, actually, we did a little video on, because she couldn't raise her shoulder.
Yeah.
It was really interesting. When I had her under general anesthesia, I couldn't put her arm on the arm board in the operating room table normally, because her arm wouldn't go up. And we're probably I think 3 or 6 months out or something like that. And she can now get her arm over her head
Yeah.
when the implant came out. So I've seen that before, and that's not uncommon. Above the muscle hurts less, but
Yeah.
it can still cause pain.
Yeah.
So
Yeah. All right. So let's talk about aesthetics, because I feel like that's the number one thing that I've had throughout the years. I mean, it's been almost 4 years. Yesterday was 4 years that I
crazy.
removed them. Wow. That's
Yeah.
crazy. And obviously I've been very open about this, and a lot of women have asked me, but their number one thing is like, well, what do they look like? And the scars and all of this. So let's talk about aesthetics, and let's talk about the options that women have. And then I want to also talk about something that I remember when we first met. I was single. I was obviously not thinking about having kids anytime soon. And you were very honest with me, like, hey, there's a chance you're not going to be able to breastfeed. And you were right. I was not able to breastfeed, And it's something that at the hospital, they were pushing it so
Yeah.
much. And lactation consultants, nurses, and I was like, I got to the point where I had to be rude to them, and I had to be like, you guys got to stop coming in my room. Like, my kid's going to have to be a formula baby. There's nothing I can physically do about that. Like, I have no milk, So yeah, if we can talk about the options and then talk about why something like that happens, maybe some listeners will feel like they'll understand more because I get hate about this all the time on social media. And people that like even strangers that ask me like, "Oh, are you breastfeeding or did you breastfeed?" And I'm like, "No." I find myself having to explain to them like, "Oh, I had four like surgeries,
Right.
including an explant," and
Right.
people still don't get it.
Yeah.
So it'd be great if you can cover that.
Yeah, I think it's unfortunate. It's like when my parents, my dad was fed only formula
Yeah,
because that was supposed to be better than milk
yeah,
back then.
yeah,
And he's in his 70s and he's still very active and strong, thank God. But I think there was a big pressure on women back then to do formula and that it was better. And
hmm
then obviously later people realized that there's some there's some benefit,
right,
right, for moms to breastfeed. There's many, right? But not everyone can do it. And for a number of reasons.
yeah.
And it's not just breast surgery, but maybe they had a surrogate or, whatever it is. So I think that it's really unfortunate that there is so much pressure on women
Yeah.
now that like you're a bad mother or
Yeah.
something because you can't physically do it or that your
Yeah.
child isn't going to develop. I mean, it would be really interesting to see like successful people and if they were breastfed or formula, type of thing.
I mean, Jack, I just showed you a picture of him.
Yeah,
You
he's
saw him
he's
when he was like
solid.
4 months.
He's well nourished.
The kid is like
Yeah.
in his own curve because he's outside the Florida curve at like the 98th
He
percentile.
looks like he's ready for the strongman
Right?
competition.
Like,
Yeah,
and he's been formula since day
yeah.
one. And but again, it's that stigma, and it sucks.
Yeah, and I'll tell you that just our own personal experience. My wife breastfed, and she was very frustrated with it. And at one point, I was like, just stop, because she wanted to do it for a year. We got close to a year, but we were at any given time only one bottle of reserve,
Yeah.
and she just couldn't produce. We have my best friend's wife. I joked that some of her family, they're from Wisconsin, and she's this tiny little thing, long distance runner, and she had like freezers full of milk.
Yeah.
Like they had an extra fridge in the garage full of
Yeah.
milk. And, Joanna would say, Heather could make how come I can't do it, And like I kind of saw, after you see it, like
Yeah.
everyone can be so judgmental until they actually see someone go through it, right?
Yeah.
After you see it, I'm like, he'll be fine.
Yeah.
Like my dad had formula. Look at
Yeah.
how ornery he is
It's
sometimes,
tough.
he's
It's tough.
strong.
And especially in today's society where like, I think and I'm so grateful that this is happening, but there's a big push for like, the Make America Healthy Again. Like I love that, right? And it's like there are so many benefits to colostrum and to this, but I just physically couldn't do it.
Yeah.
And the pressure it got to me.
I think there's bigger things, to worry about. And obviously,
Yeah.
if you can't give a child nutrition one way, then you find another way to do it.
Yeah. Yeah.
So, but the inability to breastfeed is a common consequence of breast augmentation surgery, specifically when the incisions is placed anywhere near the nipple. So
Yeah.
often it's placed through an areola incision, but if a breast lift is performed, then, typically there's some scars around the areola.
Yeah.
So the more incisions around the areola, basically the greater percentage that some ducts will be cut and there'll be scar tissue, which will prevent normal flow. Additionally, any surgery can denervate or cause the nipple to lose sensation. And
Yeah.
part of the ability to lactate is that reflex.
Yeah.
So, if you don't have sensation to the nipple or normal sensation, that reflex to produce milk, that's just not normal. So, more commonly, women who have implants placed through the breast fold or through the armpit or axilla are able to breastfeed. I mean, those have different, the armpit, you could argue there's more bacteria around the implant because you're going through those sweat glands and stuff. But any surgery can prevent a woman from being able to breastfeed. With the explants, we're often not cutting through much of the gland like we normally would when there isn't an implant because we're trying to respect the blood supply and the nerve supply to the nipple.
Right.
Because the biggest fear, many surgeries, the normal blood supply was cut. The blood supply that goes direct from the chest wall to the nipple was cut in order to put an implant in. So you're relying on that superficial blood supply.
Yeah.
So often with the breast lift, at least the technique that I've developed for it, you're relying on the skin more to lift and shape the breast after the implant's removed. And I think it does less damage to the duct. So there's a greater, and I've had many patients able to breastfeed,
Yeah.
but after an explant and a breast lift, using that technique. But I think that no matter what, with any surgery, there's a
Yeah.
risk it won't. And I don't know, even if you didn't remove, you know what I'm saying? Like, I think after the third surgery, the
Yeah.
chances are less and
Well,
less.
you did a lift, and then I had done a lift prior. So I had really 4 surgeries with 2 lifts, right?
Yeah.
Yeah, because you went through my existing
Right.
scars. So yeah, I mean, yeah, I think it was bad. I don't want to say bad luck, but I think after 4 surgeries, right? Like it just is
You
what
would
it
be
is.
higher risk to not be able to, but
Yeah.
like some women have gigantic breasts, you know,
Yeah.
and they can't walk and their back hurts, and you do a breast
Yeah.
reduction.
Yeah.
And breast reduction, typically you're cutting through the gland quite a bit. You're
Yeah.
removing a lot of gland. You're creating more scar tissue, which could disrupt normal milk flow.
Yeah.
So breast reduction, I think, has a fairly high incidence of causing scar tissue that could prevent
Yeah.
someone from being able to breastfeed. But, you know, every once in a while I'll tell patients, and then I'll get like, someone will send me a video of like milk they pumped, or, you know, and like on Facebook, I'm like, 10 years I've seen this person, you know, and they're sending me a picture of them breastfeeding their child. I mean, it's awesome. Like, so it still happens, but you know, a lot of times people can't.
Sadly,
so I think, well, I think it's the plastic surgeon's responsibility to explain all these risks to the sometimes young patient that's getting breast implants. Because you think about, now you're a mom, you have different responsibilities than you had when you were getting your first set of implants.
18. I was 18.
And I think you were working at some, I don't know, where were you? I'm trying to remember.
I was a Hooters girl.
Yeah, Hooters. Right, I didn't want to say, yeah. But I feel like I've had this,
It
you
went
know,
with the
conversation a
personality,
few times. No, but like, right. So there's some pressure, and you're like, okay, you know, I want to have implants, and where do I sign? I don't care. I'm not going to, like, it's going in one.
Yeah.
It's like when I was 18, I wanted to jump out of an airplane. I'm going to go skydiving. I never did it. I would have probably, if I had the money, just signed and done it, you know, and now, like, I wouldn't even think about, you know, so your priorities change in life.
Yeah.
But it's hard sometimes to kind of drill that risk through to the patient. But I think whoever's the surgeon, now obviously back then nobody was talking about BII.
Yeah.
But, you know, they should have said, hey, they should have said, hey, you may not be able to breastfeed. And also, by the way, if you decide to remove your breast implants, your breasts don't go back to the way they were. You know?
My original surgeon, and I won't mention any names, very well known in South Florida, didn't even let me pick the size. I mean, this was 2008. He said, I'm just going to give you what I think looks good. Turns out what he thought looked good was like Pamela Anderson, you know, implants. And I woke up and I'm like, whoa, what is this? But again, it goes back to that, you know, ignorance of being 18 and just being like, oh, I just moved to Miami. I want to fit in. This is the cool thing to do.
Right.
You know? Do you think that I mean, this is probably going to be hard for you to answer, but do you think there's a chance that if and when I'm blessed with another baby, there might be a chance I can breastfeed? Or you think if I, like, first time it didn't happen?
I mean, I don't want to say there isn't a chance, but it's hard because you know, whatever scar tissue, you know, whatever's blocking you last time, you know, and I think, you know, because you tried, right? And I know you
for like an hour and nothing would come out. I mean, it would be like little droplets that I would have to pick up with a syringe, and I was like, it's.
I don't think you're the type to, you know, half-ass anything. So I could see that where you tried pretty hard and weren't able to. So I mean, you know, I'd try.
Yeah.
But I'm not sure. You know, and I'd say most likely probably not.
Yeah. I mean, it is what it is. You know, ladies, if you're listening, think about it twice if you're getting implants.
But I mean, there's a lot, you know, sometimes, you know, when the mother has to be separated from the child for a number of reasons, they, you know, maybe the child's in the NICU for an extended period of time or whatever, that they're, you know, they can't, you know, they could try to, but there's a lot of reasons that people can't breastfeed. Prior breast surgeries, one of them. I mean, I had a patient many years ago who had a prior mastectomy and radiation and cancer at a very young age. And we were supposed to do a breast reconstruction for her using some of her own tissue, abdominal, and then doing a flap, which is a common procedure done on her one side. And during the preoperative urine test, She
She
had
was
a blood
pregnant.
test was negative. She was pregnant on the day of surgery.
Wow.
So she only had one breast. And I never asked. I wish I would have asked her if she was able to breastfeed. But I mean,
Yeah.
there's so many reasons that people can't breastfeed. But I think you can give the child. I mean, obviously, your child is well nourished
Yeah,
and looks
he's doing
strong
okay.
and healthy and
Yeah.
developmentally doing great. So God, thank God. But yeah, I mean, you did what you did.
Yeah, yeah.
You know.
No, and I did my research. I did the European formula, like, just try to do the best I can. But yeah, I've definitely gotten a lot of hate for that. So I'm glad they heard it from your mouth. They don't
Yeah.
think I'm
Well,
like lying about it.
yeah, someone's always going to have an
Oh,
opinion, but until you've struggled with it,
yeah.
I
Yeah.
I think it's
And
hard
it's
to.
crazy. Like moms like don't realize how judgy they can be sometimes and how that affects like other
Right.
moms. But okay, I know we want to talk about something really cool you're doing, but one last question before we get to it is the aesthetics of it. So that's something
Yeah.
that people ask me all the time. Like,
Yeah.
I'm scared to get them removed. I would love to get them removed, but like there's a chance I could have an inverted nipple. There's a chance where it's not gonna look the same. And my answer is always the same. For me, like they look amazing. I'm so happy. Even after gaining so much weight and losing it because I gained 60 pounds, I'm so happy with them. You did an amazing job. But for me, it wasn't an option because my health was just, I mean, they could have been like flat as a wall and I would have still been, okay, because I really do think it saved my life to remove them. But what options do they have?
Yeah. So, I mean, I think it's really important to sit down with your plastic surgeon and go over the
Yeah.
options. And there is like a little bit of a unknown.
Yeah.
We never really know because when you take that implant out, depending on the size of it, that pocket's going to collapse.
Yeah.
And when that pocket collapses, it could pull the nipple in. If the skin is stretched out, the skin could end up looking almost kind of like a raisin or prune quality.
Yeah.
You can get indentations, irregularities, and the breast usually droops a little bit more.
Yeah.
So it's really something that clinical judgment helps, but I'm still, a lot of times I'll tell patients you're in the gray zone or, we really should think about doing maybe fat transfer too,
Just what I did.
because yeah. And I think it helped us quite a bit, but everybody's different. So it's seeing that patient, but it's directly proportional to the amount of breast tissue that the patient has and the size of the breast implant. So obviously if a patient was an A cup and they have the largest silicone implant is 800 cc's.
Yeah.
So if they're an A cup and they have an 800 cc implant, over time, that's going to stretch out the tissue more and more and thin that tissue. So removing that implant is going to have a greater risk for post-explant breast deformity.
Yeah.
So that's someone we need to sit down. And every patient, I try to show them the good, the bad, the ugly, right? And I have patients that don't want to be online and, don't want to be on social media that have post-explant breast deformity. And whether we tried to do a lift or we did fat transfer or whatever. So I try to show every patient. I'm sure I showed you.
Yeah, you actually even showed me someone that kind of had my similar body type.
Yeah, and I try to like show you and we have a big enough gallery. Like the website, there's a decent sized gallery. I try to put the size of the implant and whatever. I have more patients that don't want to be online that we can show in the office. They've allowed that, but so we could try to find sometimes and give the patient that, but it's still like no two people are the same, right? So, I've had patients with a history of like smaller breasts and bigger implants turn out okay. And I've had patients with, bigger breast history and smaller implants not do as well. But in general, they usually do better, right? If they have more breast tissue and a smaller implant. Yeah. But all that being, taken, when a patient decides they don't want their implants anymore, in my practice, there's basically maybe 3 strong tools to use. Yeah. If the implant was placed under the muscle and the muscle has slid up, what happens is the rib is kind of sitting there right under the area where the skin is thinned out most. Yeah. So if you don't fix the muscle and you don't do anything and you just take the implant out, there's a higher risk that skin could heal down and cause an indentation at that level, at the nipple or below, which can cause nipple inversion. That's a terrible deformity. Yeah. And I've had patients that have had that done in other practices, and then I fix it. Yeah. And it's almost as much surgery as if we just did it at the same time. Yeah. So, fixing the muscle is one thing that helps, and I think it helps biomechanically, but it can be difficult because over time, the muscle slides up and it retracts, and you can't pull it all the way down. Yeah. And the other problem is sometimes patients and I can't remember specifically your muscle, but multiple surgeries, sometimes the muscle's torn up. It's just like shredded.
I don't think I had No, I don't recall you telling me
Yeah, I
that my
don't
muscle
remember.
was
Yeah, I don't.
bad.
Some people, it's like it's torn up so bad you
Yeah.
almost can't fix it. What's interesting with breast implant pain, once you take the implant out, even if the muscle's like toast, just
Yeah.
totally torn out, they usually do better, and they
Yeah.
usually feel better, and they usually can perform things better, like push-ups,
Yeah.
pull-ups,
Yeah.
like bench, like
Yeah.
the one everyone says is the pec deck, to
Yeah.
kind of
Yeah.
work.
Yeah. Yeah.
So they almost everybody when the implant removes, like over
Yeah.
95% say that gets better. But outside of muscle repair, we're often doing probably most commonly a breast lift
Yeah.
because the skin has been stretched out. So if a patient's had a prior breast lift scar, they already have the scar. It's an
Yeah.
easier decision. But if they haven't had the breast lift scar, then we kind of look at them and say, okay, how do we judge breast droop?
Yeah.
So, you open up the textbook, you technically have no breast droop if your nipple position is above your breast fold.
Okay.
But it's complicated because the implant pushes your fold down.
Yeah.
So when you take the implant out and the pocket
lower.
collapses, the
Yeah.
fold goes up. So the breast droop gets worse. But if a patient has a low nipple position to start, then you kind of know
Yeah.
like they already need a lift, even if
Yeah.
they get the implant replaced. So that's an easier decision.
Yeah.
But what that lift does is it rotates the tissue around and under the nipple, which allows the nipple to project better, and it tightens that skin that could prevent
Yeah.
like that prune-like quality or
Yeah.
indentations. So a breast lift is something that we do quite often. And I published a technique on that, mammary imbrication lift and fixation technique, that we published our safety data on it, and it was safer than
Yeah.
some of the published data on putting breast implants in.
Yeah.
So, and I think we get nice aesthetic result with that. And then kind of, moving on that, I don't really have a description to it, but I've added a fat transfer.
Yeah.
I've added fat transfer quite a bit to many of the explant patients.
Yeah.
And that's something you need to really talk to your plastic surgeon about because there are great benefits to fat transfer. There are limitations of it and there are risks.
Yeah.
And obviously the great benefit is a lot of patients have a little fat somewhere, especially if they haven't had prior liposuction. If they've
Yeah.
had prior liposuction, it gets a little harder. But even fit patients,
Yeah.
like
I
you,
got to gain what, like a ton of weight.
I don't think you gain that much. But
I
but
felt like I got to eat French fries every day.
if you hadn't had liposuction or cool sculpt or like any of
Yeah,
those things in the
yeah.
past, it's a lot easier because
Yeah.
that stuff all causes scar tissue, which makes it harder to harvest the fat.
Yeah.
But a lot of fit patients, I can get a little fat from the love handle, inner thigh, and patients like you,
Yeah.
you kind of have to work for the fat harder than
Yeah.
other patients because you have to spin the patient and suction
Yeah.
from multiple areas.
Yeah.
So, because you're basically doing this with modified liposuction. You
Yeah.
have to do it under low pressure so you don't pop the fat cells.
Yeah.
But it's basically liposuction. So you get the benefit of harvesting fat from an area you didn't want it.
Yeah.
We process the fat and then we inject the fat through small incisions. So if you don't have a lift, you can go through smaller incisions to
Yeah.
graft the breast and you inject the fat. Now, there are limitations how much fat you can put in the breast. If
Yeah.
you try to put in too much fat at one time, there's a higher risk, a greater percentage of fat will die. There's a
Yeah.
higher risk for infection.
Yeah.
So we don't want to pump in too much fat. The breast will only hold so much fat.
I think you did 200 on
Sounds
each one
about
of
right.
mine. Yeah.
I'd say I get anywhere from 200 to 400
Yeah.
depending on the patient's size and the amount of breast tissue.
Yeah.
Because it's kind of like, it's unfortunate, or it's ironic almost. The more breast tissue you have, the more fat I can put in
Yeah.
because it's like planting seeds.
Yeah.
So when you take that implant out, that pocket, if it collapses, it's what we want. You can't
Yeah.
just put the fat in there, it will all die.
Yeah.
Those little fat cells, they have to be embedded in vascular tissue.
Yeah.
And then the osmosis allows them to survive, the
Yeah.
diffusion of nutrients through the cell membrane. If the fat cell survives long enough, it develops a blood supply in it, then it lasts forever.
Yeah.
Or for the lifetime, right?
Yeah.
So we only can keep like 40 to 60%
I
of the
remember you
fat
telling
alive.
me that. Yeah,
So,
I remember through my drains, I think some would come out
yeah,
too.
and some I used to not do it at the same time,
Yeah.
but I figure to take advantage and
Yeah,
a lot
do
of
it at
happy
once.
patients to do
Yeah.
it once. I have had patients come back for 5 fat transfers.
Wow.
So what you can do with that is say you only get 200, right?
Yeah.
And then maybe I get 300 on the second one. So if you build on that, 100 the first one, 150 the second one, 150. No, so now you've built like a 300 or
significant
400
amount,
cc.
yeah.
So it's more and you can create more. But I think what fat transfer really helps is it's more of a shaping tool than a volumizing tool if you do one session.
Yeah.
And it can help get much more roundness on the top
Yeah.
because a lot of explant patients, they have a concavity.
Yep.
And if there are any indentations, it's really good. I get a lot of patients will do an explant lift. They look great. And then kind of like as time moves along,
Yeah.
3 or 4 months, they'll start to get little indentations.
Yeah.
So taking that secondary fat transfer, if
Yeah.
they allow it, but doing it at the same time like you did often can prevent it.
And it's safe to put, it's your own fat, right?
Well, yeah, I mean, so it's very safe when you compare it to other fat grafting procedures like the Brazilian butt lift, which is
Yeah.
the most dangerous operation
Everybody told
on the
me that.
planet. And
Yeah.
or I won't say that on the planet. It's the most dangerous operation that plastic surgeons do today.
Yeah.
In fact,
It's because there's a vein, right? You told me?
so in the buttock there are large
I don't have it done, by the way, guys. I know gossip comes out of
Yeah.
here.
We didn't have
Nothing if you do. Nothing wrong with that. But
we
I
didn't
know.
have enough fat. No, I'm just kidding. Yeah, so basically the largest vessels, right, that come off your aorta and your vena cava, like the
Yeah.
major vein and artery that go to the heart, they
Yeah.
come out and they split into hip vessels
Yeah.
that then split and go into your buttock.
Yeah.
And someone called them the Medusa head. I don't remember which plastic surgeon it was because some of these vessels are like the size of my pinky in your
Okay.
buttock. So the needle that we use to inject the fat, it's small, but it's like a big IV. It's
Yeah.
like 14 gauge. It's like the big IV, like the
Yeah.
trauma surgeons use, but it's like an IV. So it's not a huge needle. But if you imagine, you could put that needle into a vein that large. And if you inject fat directly into that circulatory system, you could have a fat embolism, which could kill you.
Ugh.
So that's why Brazilian butt lift, there's been recent legislature in Florida, you have to use an ultrasound. I can't think of the last one I did.
Yeah, I think you mentioned that too.
And it's something that like it didn't become popular probably till like 2010.
Probably like Kardashian or something.
Well, I don't know who made it popular, but back then we were trying to inject it into the muscle.
Yeah.
Because the muscle has a better blood supply and the idea was the fat would survive better. Now we know like that's what kills people.
Yeah.
So now people that do it, and I'm not a Brazilian butt lift surgeon, but they'll inject into the surrounding tissue.
Yeah.
So there's a funny story about that Brazilian butt lift surgery stuff. Okay, wait, I don't want to get distracted. Okay, during COVID, like we were one of the only offices that stayed open for a period of time because we turned it into like a trauma center almost or surgery center. And I wasn't doing any Brazilian butt lifts. But we could legally do like kids who fell in the pool and had lacerations, broken noses, like that type of thing. And I was friends with a lot of guys in the emergency room. And I said, hey, like no one wants to go to the hospital. People are like, didn't know anything about COVID. People are like dying and stuff. So I'm like, I refuse to close. Like every plastic surgeon I know, like furloughed their whole staff and closed for that period of time. And I just was too stubborn. And so I'm like, send me like any patients that need and don't want to, so what's crazy is we had people coming from Melbourne with like the kid fell in the pool and lacerations, and we were treating a lot of like nurses and stuff, families and stuff. So we stayed open because we were the only office that stayed open. We became some crazy like top hit for Brazilian butt lift Miami, which is one of the most, I learned after one of the most searched plastic surgery terms in the world.
Yeah, I bet.
So my office was getting
these questions.
Like they were getting calls. Are you doing BBLs? Like there's nothing going on during COVID from like all over the country.
Right.
I think internationally.
Yeah.
And the young lady, I remember she moved to Tampa. Amy used to work for me.
I love Amy.
So Amy's like, I'm going to quit if I have to answer another. So on our website, we're like, no BBLs, or we did something and we still are getting the calls. But yeah, so BBLs are really dangerous. Fat transfer to the breast. The largest vessel is like 2 millimeters.
Yeah.
And it's under the pack major where you really shouldn't be with the fat.
Yeah.
So like I've never heard, and I presented at international meetings.
Yeah.
Like I have never heard of anyone ever. I mean, there's probably, listen, if someone knows, send me a message, but getting a fat embolism to the breast.
Yeah.
Or dying from fat grafting to the breast. Now, I have heard people in this town who've had Brazilian butt lift surgeons, the Brazilian butt lift surgeons who've had multiple deaths even within a year.
Fortunately, in Miami, and by the way, side note, if you're listening to this and you're considering a BBL, that's fine. I mean, no judgment. Go for it. Just do a lot of research.
Yeah, and I think it's safer now, and a lot of people have pioneered kind of ultrasound technique down here, and there are people to go to, and you just want to make sure that they're using an ultrasound and doing, and there's some new rule you can only do so many a day. I mean, if that's right, if you're doing too many a day, that's a bad thing too.
And this goes along with my thought of like, do your research. I've heard of doctors that will like fly in doctors from other countries and you're sleeping. You don't know who's doing
Yeah,
what,
I mean,
you know?
yeah, that's
Scary.
pretty unethical. And I think one of the things that, patients need to look at is what's the volume.
The office is doing. That's something that I
Yeah,
loved about you. I was like your only patient that day.
Yeah, and usually if it's an explant lift, fat, especially a thinner patient like you, I got to work to get the fat.
Yeah.
That's usually the only case that I'll do that day. Sometimes we do like that with a tummy tuck, and then that's like I make the patient stay overnight. That's a big day for me. But there's this like big like how many cases, and I mean with time, like you do a lot of cases, and hopefully when you trained, because as a resident, like you operate from 7 a.m. to 11 p.m. every day for 6 years. Like hopefully you got enough training then. But the volume doesn't really mean there's spending the time to do a good job. And I think that's like, I don't think like if you're buying an automobile or you're buying some other luxury item or you want like a really nice purse, right?
Yeah.
It's like, you don't want the mass manufactured. And unfortunately in Miami, there's a lot of that going on down here, maybe more than any other state in the country, because it's like the volume, like people have multiple rooms going at the same time.
Yeah, like how are you in the same room? It doesn't make sense.
Yeah, how can I have 2 cases going at the same time if I'm your surgeon?
Exactly.
Yeah, so I think those are important things to look at. I tell patients while we're on this subject, always make sure American Board of Plastic Surgery, American Society of Plastic Surgery, they should be, because a lot of people call themselves a plastic surgeon, but they're not. And there's only one board that's recognized by the American Board of Medical Specialties to do these operations that you have.
Oh,
and that's
so
the American Board of Plastic Surgery.
To do the BBL, right? Well, to do any,
So,
right?
well, to do a BBL, you should also, because there's no other plastic surgery training for BBLs other than those that are overseen by the ACGME and the American Board of Plastic Surgery. But, But a lot of people call themselves plastic surgeons and their training's anesthesia or dermatology or whatever. So, it just like I wouldn't practice neurosurgery. My training was as long as my friend Harry Singh, who's a neurosurgeon in New York, So I think that for some reason, well, obviously it's financial, that people will claim to be or do or whatever and take, or they're taking the shortcut. I'm not sure. But finishing up on the fat transfer, I can't really forget about the risks.
Yeah.
So I think the biggest problem with fat transfer, you don't have, 100% survival. You cannot replace in one session
of the cell, guys.
Yeah.
Not the person.
The patient better survive.
Yeah.
But no, so the fat cells don't survive. So half of them survive. So you can't replace a 400 cc implant with fat in one session, right? So you might have to come back for multiple.
So someone like me that got about 200 cc's of fat, I probably got 100.
Yeah, I got 100. It's more of a shaping tool for you. Now, and you don't have the fat, but if you did come, then you could do more. But, and then, there are like some rare risks like infection. Anything can cause infection. I've seen infection more in radiated breasts. I can think of only one patient that's had an infection that in my practice for cosmetic fat transfer to the breast, and she had to come in and I had to put a needle in to drain the breast. I
almost passed.
Yeah, but that was in your breast. No, that was a different thing. Yeah. So, so that can happen. Yeah, but again, any surgery. Yeah. But the thing that is more common that we're still learning about is that some of the fat that you transfer to the breast can create either cyst or little areas of dead scar called fat necrosis.
I have that actually. Yeah, and I'm glad you brought that up because doing my regular checkup as women should be doing, and I felt some bumps. And I remember I called you, and I think I actually spoke to Amy. Hi, Amy, if you're watching. She's a mom now, so she probably
I'll tell her to tune in.
And I freaked out, and they were like, "It's just fat necrosis."
Yeah, so it's dead fat. But the problem with that is that it can resemble to the breast radiologist something that looks like an early breast cancer or a cyst or something they want to biopsy.
Yeah.
So, I have friends who are breast radiologists and I've talked to them in great detail. And one of them, I even said, like, should I even be doing this?
Yeah.
And she said, well, I understand why you do it because it looks so much better.
Yeah.
So I said, well, what should I do? And she said, it's very important regardless of age.
Yeah.
And her recommendation is to get a mammogram and ultrasound. And some people are probably going to get a mammogram. That, there's a lot of, people, right, that are anti-mammogram these days. Right. From what I've heard, it's very minimal radiation. Yeah. But you really can't evaluate the breast as well with just an ultrasound.
Yeah.
So her recommendation is to get a baseline, almost like a dental x-ray.
Okay.
So that you see, this is what the breast looks like. and to try to do that within a year before the surgery.
Yeah.
And then after the surgery to follow with an early ultrasound and then any necessary imaging. That way, it doesn't look like, okay, breast cancer didn't pop up in 3 months or whatever.
Yeah.
So if you have a clear preoperative breast imaging, and then I do the surgery, I do the fat transfer, we do an ultrasound 3 months later, and they say, okay, there's some cysts here. They just popped up. It's probably fat necrosis. Oh, wait, her history, she just had surgery. Let's just repeat the imaging or,
Yeah.
and I think a lot of the breast radiologists down here see a lot more fat transfer.
Yeah.
I have had some patients from other places in the country, and then you're like, you wonder if, the radiologist in Nebraska sees as much. So,
Yeah.
What you want to try to avoid is unnecessary breast biopsies.
Yeah.
But every patient currently in 2025, like they need to know if you're going to get fat transferred to the breast, there's been many studies that show that there is no evidence of breast cancer from
Yeah.
fat transfer in the breast. And there's one plastic surgeon at University of Chicago, I think the last name is Song, I can't remember right offhand, but he studied this intensely and showed that there's no risk of cancer with fat transfer of the
Yeah.
breast in his studies. In fact, most surgeons that specialize in reconstructing the breast after breast cancer will fat transfer the breast.
Yeah.
So we think it's safe from that regard. But the problem is the radiologist might see it, especially if you never had any imaging,
Yeah.
and say, oh my God, she's a young mom.
Yeah.
It's probably fat, but I can't sleep at night. We got
Yeah.
to biopsy it.
Yeah.
And then you're getting needles, and that brings a lot of anxiety. So
Yeah.
patients need to at least know about that. And then they have to weigh the aesthetic benefit versus the
Yeah.
potential for more breast imaging, MRIs, maybe even a needle biopsy in the future.
Yeah. It's a lot of info. I mean, do you get the implant? Do you not get the implant? Do you get the fat transfer? I mean, honestly, like it's a scary world, but you know what? Coming to someone like you is great because since the beginning you've always been very like, this is what can happen, this is what cannot happen, So if you're listening, make sure you're going to either Dr. Lampert or somebody who is going to be very open about all of this stuff.
Yeah, I mean, I think they should take the time. You can't do it quick. And that's,
Yeah.
I think when, I probably spent like an hour or 45 minutes,
Yeah.
usually spend like
Yeah,
30
yeah,
minutes to
yeah.
an hour with patients on that initial consult.
Yeah.
And it's easier when they come in and they say, like you were like, I'm removing my breast implants
I
no
was,
matter
like,
what.
sold, yeah.
But I get a lot of patients, they'll come in and they'll say, well, I might replace them. Then you get into this like, okay,
Right.
we got many crossroads and you
Yeah.
got to decide. So then it's just informative. I try not to make any decisions, right? I just try to give you the information to make the decision.
Yeah, I love that. All right, so you do something that is so cool and it's so thoughtful and it's so amazing. And you have a charity called the All for Moms charity, right? And what you do is that you actually give free surgeries to moms in need. Tell us a little bit about that.
Yeah. So we do that on May 21st, which is my mom's birthday. And she passed away 2020.
Okay.
Not from COVID, but during that whole weird era. And, she was always very obviously supportive of me. I wouldn't be where I am now without both my mother and my father.
Mothers are amazing.
But yeah, and you don't, it's weird. You don't realize, like I'd say, initially I would say you don't realize how amazing moms are until you lose your mom, but even more so until you have children yourself.
Yeah.
Because I think that seeing what my wife goes through, really just an amazing woman and makes you appreciate your mom so much more because, I wish my mom met my son. She met her other grandson.
Cry.
Yeah, I might too. You got Kleenex. But yeah, I wish she met him for like that, because I know she would have loved, like it would have been like very amazing experience for her, but also for me just to realize,
Yeah.
and give her that thank you. But I used to do a lot of mission trips before my practice got established and busy. And most of those were in developing countries for pediatric charities, cleft lip, cleft palate. Sometimes when the skull doesn't close, the soft spot closes too fast, called craniosynostosis. And, been kind of to a lot of cool places and done a lot of neat things. And then as my practice got busier, I used to participate at a local charity down south by you, where you are now. And that was every year. And that was really cool. It was at Baptist, the Children's Hospital. They had a Day of Smiles, it was called. It was once a year in June. And, it was operating on kids again. And my mom was always, that was what she would brag about. Like my mom designed my office. My mom and dad both worked on it, but my mom was an interior designer.
Yeah.
She had probably like 6 designers or so working for her in Chicago. She had a very, she made it in that field, and many awards. And we had, I met a lot of at the time I was like a Chicago Bears fan and Bulls. And I met a lot of these people. My mom had designed their houses and stuff. So it was really cool. And then she got cancer, and she fought it. She had surgery. And then it came back, and she battled metastatic cancer for 12 years. And she couldn't run her practice. And it was like her love.
Yeah.
Like, and it was her baby too.
Yeah.
When I hear you describe like, this is your baby, that's your baby.
Yeah.
So, she had that love for her, and she was truly an artist and trying to design a space and see it, and really an architect in a lot of ways too, and an engineer. She had to take a lot of engineering classes, and she was NCIDQ. So it was pretty cool to see when she designed my office.
Yeah.
So I kind of like forced her out of retirement to do a little condo project.
Yeah.
And then a few years later, my dad really pushed me to build a plastic surgery facility with a AHCA licensed surgery center. And we got it through, and it was really, they did so much work to make it happen. It never would have happened. And we won an award from the American Society of Interior Design for healthcare design in South Florida. And my mom's got many of these ASID awards, but like this one was cool because it's the only one she did for her family,
right.
And then she passed away a few years after that. So she got to see that, which was cool. But I owe a lot to her, and she was always very proud of those charities. During COVID, they kind of dried up, like there wasn't anything going on. She passed away. And then I think it was like a year after, something like, it's like the birthday, it's like right along Mother's Day.
Yeah.
It's like hard not to be sad or depressed about it. So, I thought about it, and around that time I got like a message I'm trying to look for that old message still, and I can't find it. It was on one of the social media things. It was a DM or maybe a comment.
Yeah.
And it said, I'm a single mom. I think it was breast implant illness and pain. My breast implants are killing me.
Yeah.
And I can't afford surgery. What can I do? And I was thinking about it, and I was like, it would be really cool to do a charity surgery day on my mom's birthday, and try to make a positive thing of it. So that's kind of how it started. And then it got a lot of great,
feedback,
and the first year we did it, it was cool. Like someone saw it on the social media, kind of went through, it made it onto some of like the mainstream news.
Yeah.
And then my aunt, my mom's sister, saw it in Chicago on WGN.
Oh, that's awesome.
So it was just really cool.
Yeah.
And then we've just, it's been a fun experience for the whole group.
Yeah.
So it's coming up this year again on May 21st, which
next month.
is a Wednesday.
Yeah.
And then April 21st is the deadline to apply.
Yep.
So it's for moms, right? And it's for moms who need plastic and reconstructive surgery that don't have the financial means.
Yeah.
Or they're either uninsured or underinsured. So, we're going to provide that surgery free.
That's amazing.
And this year we're opening it up to out-of-state applicants.
Oh, wow. Okay,
which is
good.
cool. We just we started with just South Florida, then we did the state of Florida, now we're doing out-of-state. But they have to demonstrate the means to stay.
Okay.
Because like, as you know, the post-operative care is as important as the surgery.
It's very hard. Yep.
Because you had that thing, right? I had to drain the little fluid.
Yeah.
You had a little fluid
in my back.
In your back.
That's
from
what
where
you
I
had to
lipoed
drain.
you.
Yep.
And I put a needle. It's called a stroma. It's a very common minor complication.
Oh, yes.
But if you don't do it,
it was fine, but I was just scared and I passed out.
But if you leave it there, it can become chronic.
Yeah. Yeah.
And it develops like almost like a capsule around it or like a bursa. So, I don't want patients to come in and have surgery disappear. So, we want them to, if it's a major surgery, it's usually staying at least 2 weeks.
Yeah.
So we're opening up to out of state, which I think will be interesting. And then, we're doing this for patients who are basically healthy.
Okay.
It's reconstructive surgery. So it could be anything from a broken nose, a trauma, painful breast implants, breast cancer reconstruction, skin cancer
Wow,
reconstruction,
you're
C-section,
doing a pretty
scar
big,
revision. Well, even we had
yeah,
one like apply for earlobe. The baby tore the earlobe, tore
right.
the earring out of the earlobe. Sure, why not? Whatever it is, if it's I'm not doing facelifts, right, or brow lifts or eyelifts or whatever, or Botox, But we might do some laser scar. And we
Okay,
saw one patient applied, and she has like a port wine stain,
okay.
which is like a congenital birthmark that does well with laser. I'm trying to maybe bring in a laser, but so it's a fun day for
Yeah,
everybody.
that's awesome. How can they apply if they're listening to this?
So if you go on the website, which is www.lampert, LAMPERTMD.com.
Yep, we'll make sure to put it in the show notes.
Yeah. So there's at the top, there's a All for Moms button you can click.
All for moms, and they
Yeah.
can apply, and they have until April
21st.
21st.
1 month. It gives us 1 month to go through them.
Exactly. So literally,
easy.
like, this is gonna come out in a couple days. So by Wednesday, so they'll have almost a month to apply.
Yeah, patients have to be healthy enough to undergo ambulatory surgery. So, if they have multiple medical problems or uncontrolled diabetes, or they need to stay in a hospital after surgery, we can't do that.
Right.
But it's for most of the procedures we do are ambulatory surgery.
Amazing. And guys, I mean, ladies, women, amazing moms, parents watching. I would not bring him on the show. I would not have him do surgery on me. And John, you also did surgery on John. If we call that
I don't know if I can
surgery.
comment. I don't know. I don't know about like the HIPAA release.
It's fine. But, like if it wasn't somebody that I trust. Dr. Lampert, thank you so much for being here.
It's my pleasure.
Appreciate this so much. Ladies, go apply. Make sure you're following him on Lampert and MD.
Yeah,
Instagram.
it's Lampert MD. It's my Instagram is Joshua_Lampert.
Okay.
But there's a Lampert MD too. You could find me.
The easiest one is
Yeah.
Explant Miami. That's the one I recommend to everybody.
Yeah, we have that one too.
That one I'm sure gets a lot of traffic. Awesome. Well, thank you so much.
My pleasure as always. Thanks,
Awesome.
Liz.
Thank you for sharing a little bit of your precious time with me today. I know your time is gold, and I'm so honored that you chose to spend it here. If this episode spoke to you, don't forget to hit subscribe so we can stay connected. And if you know a parent who needs to hear this, please share it with them, because none of us are in this alone. I'll be right here next week with more tips, stories, and reminders that you matter. Until then, remember, taking care of yourself isn't just for you, it's for your kids, for your family, and for your sanity. You're doing an amazing job. Take care of yourself and keep making space for your happiness.